All right. Well, I want to thank Oley for inviting me to present here. I just got the tail end of the last talk, which was also about IFALD. You'll hear a little bit different perspective in my presentation. Just a couple of one conflict. I'm a minor shareholder of Prevalence Therapeutics, who's actually developing choline. I hold about 1/10 of 1,000%, but wish I owned a little bit more, but I don't. In terms of the liver abnormalities during parenteral nutrition, these were first identified in children around 1971. And parenteral nutrition, as we know it now, was started around 1970 or so. So it was really pretty quickly thereafter where this complication of either the underlying disease or the therapy was identified. And now the incidence of what we call IFALD. Now, it used to be called parenteral nutrition-associated liver disease, or PNALD, but IFALD is really the better term, as you heard in the last talk, because it may not necessarily be related to the components of the parenteral nutrition, but may actually be more related to the underlying disease. And I'll be talking about that today. About 2/3 of patients actually may develop some liver test abnormalities with these the liver enzymes. They're often called liver function tests, but that's actually incorrect, because the AST and the ALT don't tell you anything about liver function. They're simply enzymes that are contained within the cells in the liver, and when those cells are injured, these enzymes are released and they increase in the blood, but they don't tell you anything about the function of the liver. In fact, the liver actually can function normally until 80 or 90% of the liver is destroyed. And so by the time that the bilirubin starts increasing, for example, albumin starts decreasing, these are more liver function tests. The liver is very resilient. And like a salamander regrowing its tail, the liver also has the capacity for regeneration prior to the development of severe fibrosis and cirrhosis. The bilirubin in adults is not generally elevated, although it's usually a hallmark of IFALD in the preterm infants, as you probably heard in the last talk. But again, these liver tests are really not only non-specific indicators of liver disease, but they're also insensitive. And if one did a biopsy or imaging of the liver, one might see significant abnormalities even with normal liver tests. And in fact, when cirrhosis occurs, the AST and ALT are often normal. In this study here, and again, this is old data, but just because it's old doesn't mean it's wrong. It means that we discovered some things a long time ago, and we've had many years to forget them. This is a study of patients who were on long-term home parenteral nutrition for several months. And as you can see here, there's an initial rise in the AST, which is one of those liver enzyme tests that I was talking about. But really, after about 8 to 10 weeks is when these tests really become much more significantly elevated. So if you're only on parenteral nutrition for a short time, or you only require parenteral nutrition for a short time, and your intestinal function returns, the liver generally will return right back to normal once absorption is normal. So it's really the more long-term issues where individuals are on parenteral nutrition for more than 10 or 12 weeks or permanently where we get more concerned. And in fact, actually, IFALD is the most important indication for a small intestinal transplant, as well as a liver small bowel transplant. And I'll talk about that towards the end of the presentation. Now, this is some older data from Paris, France, where they found that there's an increasing incidence of cholestasis. Cholestasis means that there's a lot of bile that's kind of stuck in the liver. And I'll talk about the definition of how IFALD is defined in a minute. But the important point here is that these are patients that were on parenteral nutrition for 2 years, 4 years, and 6 years. And the longer that they were on parenteral nutrition, the more likely they were to develop these liver abnormalities. But remember, we're not really all that concerned with just these enzyme abnormalities. Again, it suggests that the liver is being harmed, but the liver function can still be completely normal. What we're more concerned about is when more severe liver disease develops. These would be certainly indications for a transplant. In fact, actually, I would suggest that once there's extensive fibrosis or cirrhosis, the bilirubin significantly elevated, we have the liver is sort of like a dam, if you will. And when you get a lot of scar tissue in the liver, everything sort of backs up in the liver, just like closing the gates on a dam. And the blood actually that would normally flow through the liver then backs up into more proximal veins, like in the esophagus, where they're very thin. And these veins are called varices, and they can pop and bleed like stink, and it's a cause of death. So we don't really ever want to see that happen. And so I would suggest actually in this situation, these are people who actually should have been evaluated for a liver transplant, for an intestinal transplant prior, because what we don't like to do is to do an intestine and liver transplant. That means that the individual was evaluated too late, because if we're able to transplant intestine, then liver disease often reverses. And given that, at least in my opinion, the major cause for IFALD is the intestinal malabsorption, when you replace that bowel with more bowel and absorption improves, then IFALD does not recur. And to support that, if you just transplant the liver and not the bowel, IFALD comes right back. And so the important thing here is, again, to jump on these things in a hurry. We don't like to see liver small bowel transplants. And the reason is that if, for example, the transplant graft of a bowel does not survive, all you have to do is take it out and go back on parenteral nutrition, and perhaps until another bowel is available. If the liver fails and you take that out, you're in deep doo-doo. So we don't really like to see that. Now, how significant is intestinal failure associated liver disease? Well, in this study from the Brigham in Boston, about 20% of the deaths in their patients were related to IFALD. Now, most deaths actually during parenteral nutrition are not due to infections or not due to liver disease. They're really due to the underlying disease. But of the complications of parenteral nutrition, this is certainly the most deadly. Now, in infants, and this slide, when it was transferred to the Oley outline, or the format, I should say, the percentages here sort of dropped off the slide, which I didn't realize till about a half hour ago. But in any case, as you probably heard in the previous presentation, the prevalence of IFALD is much higher in infants, and really not just infants, it's really preterm infants than in older children or adults. And so I really tend to divide IFALD into two groups. Those who are preterm infants and everybody else. And the incidence may be even as high in some studies, as high as 65% in the preterm infants, although that incidence does seem to be decreasing. And of course, the longer that you're on parenteral nutrition, the more likely it is to develop. Now, what's the definition of IFALD? Well, there's a couple of different definitions, and I actually proposed a combination of these to the CDC, and this will be adopted for a disease code. So IFALD will actually be recognized as a disease next year. And this is essentially liver injury that results from malabsorption or the parenteral nutrition solutions, or both together, when we've excluded all other known abnormalities, which would include, of course, various hepatitis, which could be from viruses or from drugs, alcohol, certainly, and obstruction of the bile ducts. Now, of course, there is some degree of biliary obstruction that we often see in the biopsies anyways as part of IFALD. And so essentially, we're looking for not just an isolated abnormality here, but some chronicity. And again, even though I said that these liver enzymes are nonspecific and insensitive indicators of liver disease, these markers that we have, if they're elevated for 6 months or more, then that would be a diagnostic of IFALD. Again, with other etiologies being excluded, and children, because and when I say children, again, it's the preterm infants when they have persistent elevations for at least 6 weeks. Imaging is important. We try to avoid liver biopsies when we can, but liver biopsy is generally going to be required at least for an initial diagnosis, but not for following people. A liver biopsy is a potentially morbid or dangerous procedure because it is done a little bit blindly, and there's a risk of bleeding. These days, we tend to do them in radiology, where the radiologist actually puts a catheter in through a vein, feeds it into the liver, and does the biopsy from inside the liver, actually, so that the liver itself sort of presses on that little hole where the biopsy was taken, very similar to if you have a cut in your arm and you put your finger on it and put pressure to stop the bleeding. If you do a biopsy from the outside, there's really nothing to push on that that hole, and that's one of the reasons why there are more complications. One of the things that's important to recognize, though, is that in all cases of IFALD, there's going to be both steatosis, which is fat, and I'll show you some pictures of it, as well as cholestasis, which means bile backing up in the liver. In some people, the fat predominates, and others, the cholestasis predominates. In the preterm infants, it's mostly cholestasis, but there's also some fat. In adults, it's primarily the steatosis or fat with a little bit of cholestasis, but there are adults where the primary driving factor for IFALD is actually the backup of bile or cholestasis. Now, everybody's probably heard about NASH, a non-alcoholic steatohepatitis, or NAFLD, which stands for non-alcoholic fatty liver disease, which is an earlier precursor of NASH. This is one of the biggest things that, around, because patients with diabetes, for example, and metabolic syndrome are at substantial risk for developing NAFLD. And it may actually, and is, I believe, probably the most prevalent reason for liver transplants in the United States, and if not, it shortly will be. And IFALD was always thought to be one of the causes of NAFLD or NASH, but in reality, it's not, and they're really quite different. So in non-alcoholic fatty liver disease, or NASH, we don't have any malabsorption. In fact, people are absorbing too many nutrients because they're usually obese. Not everybody, but certainly well over 90% of the patients are obese. We did a study with Keith Linder at Mayo Clinic, and we looked at choline concentrations, and I'll talk about choline in a little bit. What's interesting is, of course, in the patients on parenteral nutrition, about 85% of patients on home parenteral nutrition have decreased plasma-free choline concentrations. Charlene Comfort showed the same thing on the East Coast in the patients at Penn as well. But in the patients with NAFLD, they generally have a normal choline concentration, or it's even elevated in some patients. Cholesterol is completely different. These patients have cholesterol problems, hyperlipidemia, we call it, increased triglycerides. When a total cholesterol concentration in a patient that's on home parenteral nutrition could be as low as 10 or 20. Never going to get a heart attack from increased cholesterol. In fact, actually, decades ago, parenteral nutrition was thought to be a potential cure for heart disease because of the malabsorption. It drove cholesterol levels down to almost undetectable. One thing also that's prevalent in non-alcoholic fatty liver disease is a resistance to insulin. You need a lot more insulin. We don't see that in parenteral nutrition. Many people do require some insulin, but that's only because you're getting so much dextrose, so much sugar in a short period of time. And of course, medications contribute. The prevalence, though, of NAFLD among the patients with the presence, I should say, of severe liver disease is very rare, though, among NAFLD, and it may take 10 or 20 years to develop cirrhosis. In preterm infants, cirrhosis can develop in as little as 3 months of the severe malabsorption. And there's also some differences in how the tissue looks when you take a biopsy, which I won't really get into. Now, this is a biopsy of a patient with IFALD that shows what I call steatocholestasis. So you have fat; these are fat globules here, and you also have some cholestasis here, which is kind of the yellow stained. That's bile. And this is just one example where I have both, because it's hard to see both in the same picture. They could be in different parts of the liver. But in someone that has predominantly fat, this is what all these fat globules look like. And what makes IFALD a little bit unique among the various fatty liver diseases is that you often have a combination of what we call macrosteatosis, these big fat globules, and microsteatosis, which are these little, these much smaller fat globules. And this is pretty unique to IFALD. It's very rare to see microsteatosis at all in non-alcoholic fatty liver disease. Jamaican vomiting sickness, you'll find that. I've been to Jamaica, but I've never seen anybody that had that. There's, I think the bite of the Trinidad scorpion might also do that as well. Valproic acid toxicity can do the same thing as well. Now this biopsy here, it's actually from a child, shows cirrhosis. All this blue staining is all the scar tissue or the collagen that builds up. But again, liver failure can actually develop in the absence of cirrhosis. And we certainly don't want to wait for this to happen because this is irreversible. Now, what are some of the risk factors for IFALD? Well, coal fat in Amsterdam, actually not Amsterdam, I forget the city in Holland, but they showed us some of the things that were pretty obvious, but sometimes things that are obvious don't turn out to be really true when we actually look at the data. But if the citrulline, this is CIT means citrulline, which is kind of like an amino acid, it's a good indicator of the amount of intestine you have, not just the length, but the intestinal mass. And so if it's low and you have less than 100 centimeters of intestine, that substantially increases your risk for developing IFALD because absorption is substantially decreased. Now, FGF is fibroblast growth factor 19. This is actually an interesting a growth factor because it actually inhibits the synthesis of bile salts. And bile salt diarrhea actually can occur in people who've had even just a little bit of the end part of their small intestine removed, because that's where bile salts are. When bile salts are produced in the liver, they're stored in the gallbladder, and when you eat, they're released because they help you to absorb fats. They make fats more soluble so that the intestine is able to absorb them. And if you and they pass through the intestine, they get released from the fats, and they get reabsorbed in the end part of the intestine and go back to the liver. The problem is that people who've had the end part of their intestine removed, these bile salts don't get reabsorbed, and they pass into the colon if you have colon, and can injure it and cause diarrhea. And so there's appears to be a feedback mechanism. When they get absorbed, they go back to the liver, so it decreases the need for more production. But if you can't reabsorb these bile salts, and they pass into your poop or pass into the colon, then there's this need to continue to synthesize more and more and more. And so the fact that the fibroblast growth factor 19 is low in these patients may simply signify that the body needs to make more bile salts because it's losing so many bile salts. And it may not really be a risk factor at all, but just may result from the fact that you have an ileal resection and maybe not even short bowel syndrome. So sometimes things that look like, there's an association, but an association is not proof of cause and effect. Now, I only caught a little bit of Kishore's talk, but he mentioned about I think I heard him for about 30 seconds, but I was there when he mentioned about something about the importance of the colon, and the colon is actually very important in short bowel syndrome because the colon in people who have all their intestine doesn't do a whole lot other than absorb about 1 liter of fluid a day, a few amino acids, a handful of medium chain triglycerides, and some sodium. But in a patient who is missing most of their intestine, the colon then can absorb carbohydrates by what's a process called carbohydrate salvage, where the carbohydrates that are not absorbed in the small intestine pass into the colon and they're fermented by bacteria. In fact, people talk about bacterial overgrowth in patients with short bowel syndrome. That's great. It's not a problem. It's a good thing because those bacteria ferment these unabsorbed carbohydrates to for you to be able to absorb energy. In fact, maybe as much as even 1,000 calories a day. And what's interesting here is that the more colon you have, in this study also from Paris, the lower likelihood of developing IFALD. And of course, obviously, the more intestine you have, the less likely you are to develop IFALD because your absorption is substantially improved, not only for macronutrients like protein and amino acids, protein being absorbed in the form of amino acids and carbohydrates, but of course the micronutrients and choline even as well. Now, how can we predict IFALD development? Well, again, the folks from Holland developed a model here to be able to predict this and predict survival. And again, the citrulline was important, how much intestine you have, this fibroblast growth factor, but again, that may just simply be a marker of the distal ileum being removed. And of course, the more parenteral nutrition you require, because the worse your absorption, the less intestine you have, the more parenteral nutrition you're going to need. But it's not a perfect equation here. It's not one that we use, but it's a good first attempt. How do we prevent IFALD? Well, we want to avoid overfeeding, because one thing that we've found out in the 1970s and early 80s was that more was not always better. I mean, that's an American idea that if enough is good, more must be better, but that's not always true, and it's certainly not true when it comes to nutrition. We know that, not just from those that are on parenteral nutrition, but those who are not. We want to preserve as much intestine as we can, take advantage of the colon. I still see patients that don't have the colon reanastomose to the small bowel. Got to maintain oral intake. If you still have your gallbladder, it gets the gallbladder to contract, which is important. Cycling parenteral nutrition, again, this is data from the late 1970s, but it does suggest that if you get your parenteral nutrition overnight, for example, versus continuously over 24 hours, not only is it much more convenient, but it also does decrease the risk of IFALD. Limiting lipids, and I'll talk about this a little bit more, but sometimes we jump to conclusions without really the appropriate data. And I'll show you some slides and talk about that. We want to avoid sepsis because we want to avoid sepsis. Although people always talk about infections as a cause for IFALD, but I'll tell you this, there's not a single shred of evidence, even in animals, that sepsis causes IFALD. When you are septic, there's often an increase in AST and ALT. The liver gets injured, and not only from perhaps the bacteria and the infection or the low blood pressure, but also the antibiotics that are used to treat it. But that's transient. In 100% of the cases, that will resolve within a couple of weeks of the infection being taken care of. There's absolutely not one shred of evidence that sepsis or infections at all lead to IFALD, despite what everybody seems to say. Now let's go back to the lipid here. Now, again, this came from the Parisian study, where they randomly divided their group of patients into those that got more or less than 1 gram per kilogram per day of lipids. And this is the whole basis for how we want to give people less than 1 gram per kilogram per day. And they found that the probability of getting liver disease was much less in those people that got less lipid. But those people that got less lipid also had better absorption and had more intestine. And there's been no study where patients have started parenteral nutrition, and where one group, say, gets 2 grams per kilogram per day and one group gets 1 gram per kilogram per day, and follow them out, where there's an equal number of patients with the same amount of intestine in each group. So this is really just a hypothesis. We don't really have proof here. Carnitine deficiency, I still see people that get carnitine in their parenteral nutrition, and I'm thinking, say it ain't so. Why? Well, we have data from the 1980s here, okay, where it doesn't work. Okay, so they have a low plasma carnitine concentration, but when you give them carnitine, it doesn't make any difference. In fact, it doesn't make any difference for much of anything other than increasing the carnitine concentration, because to be really carnitine deficient, you've got to have a carnitine concentration that's about 10 to 15% of normal. What we see in parenteral nutrition is it's about 50% of normal. So even though it's decreased, it does not mean that you're carnitine deficient. You don't need it. How do we treat it? Well, there's no FDA approved treatments. Everybody thinks the fish oil-based emulsions are a treatment. Say it ain't so, because the FDA said it. And so FDA looked at the data and they said, this doesn't treat, there's no data that shows that this can successfully treat IFALD. We're just improving the numbers. The bilirubin decreases, but when you look at biopsies, fibrosis can progress and the liver disease can continue to get worse. And in fact, even in animal studies, Doug Byrne presented a study in a workshop we did at the FDA a few months ago, where the bilirubin in the animals decreased when they used the fish oil-based emulsions, but the liver biopsies were identical, whether they had fish oil-based emulsions or whether their phytosterol levels were high or low. The phytosterols made no difference whatsoever. We also know that fish oils don't prevent the development of IFALD. And the studies that have been done, unfortunately, have basically compared infants that received fish oil versus those that received like intralipid, for example, where they got 4 grams per kilogram per day of lipid, far more than what we would ever give anybody today. So what I think the data shows in the infants, at least, is reducing the amount of lipid probably, even though there's no prospective data, probably does decrease the risk of IFALD. But what's not clear is that using fish oil itself is a treatment for IFALD. And in fact, actually, it's approved as an energy source, just like anything else in individuals with IFALD, but not as a treatment for IFALD. An important distinction, because why? Fibrosis may actually still increase. This is our biggest concern. Ductal proliferation increases, and steatosis may continue to increase as well, despite being switched to fish oil. So let me get to choline here. It says it was recognized in 1998. It's actually 1898. It's basically pretty ubiquitous in the diet. So choline's in everything. I mean, it's more predominant in organ meats. And so there is some thought that because we're eating so-called healthier diets these days and less organ meat, that you get less choline in, and choline deficiency can develop. And there's some data to suggest that may be true, certainly in alcoholics, but also potentially in pregnancy, where the needs are increased. But it's really not so much an issue for normal living individuals, even though there is a DRI, a dietary recommended intake from the Food and Nutrition Board. But it's really probably more important in people with severe malabsorption, and not only those with intestinal failure, but also cystic fibrosis, for example, where choline deficiency has also been developed. So it's essential for hepatocytes. Those are the cells that make up the liver, because the choline is a methyl donor. And so this is a methyl group. This is used for DNA repair, just like B12 and folic acid. So if you're deficient in choline, and studies show that these in cell cultures, that the liver cells die and there's a lot of damage to the DNA. And also, if you put a rat actually on a choline-free diet for a year, most of them will develop liver cancers. And so the reason that the choline has not been supplied, though, is because in a normal individual who's able to eat and doesn't require parenteral nutrition, their liver is able to synthesize choline from the amino acid methionine. But that doesn't actually happen in patients who get their nutrients intravenously, and I'll show you some data on that. What is choline used for? Well, a couple things. Number one, choline is the precursor for phosphatidylcholine, which is a major constituent of every cell membrane in the body. It also is a constituent of VLDL, very low lipodensity protein, which is how fat is transported out of the liver. So the reason the fat builds up in the liver is because you don't have enough VLDL to transport it out of the liver. Choline also stimulates bile secretion as well. And so with choline deficiency, the bile also can back up in the liver. And so that's how you can get both things, both steatosis as well as cholestasis, as I discussed. Now, in this study from the University of Iowa, where they used normal medical students, and what they did here is, I'm not sure they were really normal students, but actually they weren't medical students. They probably wanted to get into medical school. They were undergraduates. They put them in a research center, and they put an NG tube in them and an IV, and they gave them methionine, the precursor for choline. They didn't measure choline, but they measured cysteine concentrations, which is produced in the same pathway that in the liver that choline is. And when they gave them, this is when they were eating normal dorm food or whatever, it's always best, even though they don't think so. The cysteine levels decreased a little bit. But when they gave the methionine IV, the cysteine concentrations were almost undetectable. When they gave the methionine back to the same people through the NG tube, they increased. And of course, when they started eating dorm food, they got even much better. So or much higher. So the same thing happens with choline. So what happens is when you eat, nutrients are absorbed through what's called the portal vein from the intestine, and they go through the liver and they get metabolized. But when you get your nutrients via parenteral nutrition, the first place they go is the heart, then the kidneys, and back around to the liver. So metabolism for these nutrients is quite different. And this actually is an illustration from a paper that Tim Santago and I did, where it shows all the metabolic pathways of how choline is created. It's kind of complicated. I won't go through it, but I want to show you that right here is where Tim found why where there's a blockage in the pathway and why the liver can't produce choline from the methionine that's in parenteral nutrition. And in fact, if you measure methionine concentrations, methionine, of course, is one of the amino acids supplied in parenteral nutrition. They're often somewhat elevated in patients that receive parenteral nutrition because of the inability to metabolize it. So again, with choline deficiency, you get both the steatosis as well as the cholestasis, and in experimental studies, this ends up in cell death, which is the pathogenesis for IFALD, at least as far as choline goes. Now, in an early study here, we looked at in 13 patients, excuse me, the correlation between liver Hounsfield units, which is the density of the liver by CT scan, and which you can use to determine how much fat's in the liver, versus the choline concentration. And the higher the choline concentration, the more dense the liver was. And again, proof of association is not proof of cause and effect. And similarly, in these slides here, where we looked at both the AST and the ALT, you can see that the lower or the higher the choline concentration, the more likely these enzyme levels were to be normal. And when choline was low, they were much more likely to be abnormal. But again, an association, not proof of cause and effect. Similar study here from Emory that Chawla did. Again, these are all these pathways of this what's called the transsulfuration pathway in the liver, where choline is synthesized, as well as the cysteine and the other molecules. Those that received parenteral nutrition had really low choline levels. Those that got Vivanex, which is a particular enteral formula, had low choline levels as well, not as low as parenteral nutrition. And those that got a regular hospital diet, it was totally normal. Even so, you think hospital diets, are really horrible, but as far as choline, they're actually pretty good. And this is in cirrhotic patients. Those that didn't have cirrhosis have an increased ability to make choline, but the levels were still fairly similar. And so we had to take some guinea pigs here. Maybe some people that are even listening to this call. Quite a number of years ago at this point, we had developed an IV choline preparation and gave it to individuals in a placebo-controlled design, where some people got a fake choline. It wasn't really the choline. And we looked at the choline concentrations, and obviously they're really quite low. Normal would be, up here somewhere. And those that got the choline, obviously, they substantially increased. Those that got placebo or the fake choline, they remain the same. And this is after we stopped the choline in the parenteral nutrition. So obviously, it's like giving, if you give vitamin C in parenteral nutrition, you measure it, it's going to be increased. If you stop it, it's going to be decreased. I mean, that's kind of common sense. But we also looked at the liver. And you can see here, this is the spleen, and the liver and the spleen should be about the same density, but you can see here that the liver here is just, it's fat all over the place. And after 24 weeks of choline, you still see a little bit of fat here, but pretty much the fat is resolved, and the liver has pretty much the same density as the spleen. And you can see here in placebo, the placebo group, the liver density pretty much remained the same. This is actually related to one patient who got placebo, who her absorption just improved during the study, a 65-year-old woman, for reasons that are not clear after 7 years of being on parenteral nutrition. And she gained weight, and we couldn't change anything during the study, but as soon as the study was over, actually we were able to stop her parenteral nutrition. It was a pretty amazing case. But you see clearly here there's a difference in terms of how the liver density improves with choline. And this area, we stopped the choline at 24 weeks, and you can see the fat starts to return. Cholestasis also improved. You see a marker of cholestasis here with the AST decreasing. And when we make it a little bit more specific, where the alkaline phosphatase had to be 1.5 times the upper limit of normal, there's even a more dramatic difference. But again, small study. This is not absolutely a proof that you got to have choline. We need more data on this, but it's certainly highly suggested. Now, is choline the answer here? Well, it's a contributor. I mean, this is a multifactorial problem. There's probably a lot of different things that go in here. But if we look at this really eloquent rat study, those rats that just got a saline infusion, they're eating rat chow, just like hospital chow, dorm chow. It's always the best. They've got normal liver enzyme. If they give them endotoxin, which is like being septic, but they have enough choline, their liver's fine too. If they take the choline out of the diet, they get a fatty liver. But still, the AST goes up, but the liver doesn't. There's some injury to liver, but it's not bad. But if we have a fatty liver and we add endotoxin, which is like when you're septic, to the fatty liver, look what happens here. The liver is really severely injured. And if you give an antibody to the endotoxin, then you're back here with just the fatty liver. So the concept here is that, well, if you don't have a fatty liver to start with, then it doesn't matter if you get septic. But if you do have a fatty liver from choline deficiency and you get septic, then you're in serious trouble.
Dr. Buchman?
Oh, yes. Do you need me to, am I over? I wasn't paying attention to the time.
Yeah, you're way over. So if we can wind this down, that would be fabulous.
Yeah, but that's the end of the talk, basically. How do we follow? Just a couple more slides. I want to show how do we follow a patient with IFALD? Well, we don't know. We don't want to do serial biopsies because these can be dangerous, as I mentioned. When the bilirubin becomes elevated at all in an adult, they do need to be evaluated for transplant, not just following the bilirubin, because then you end up having to transplant the liver as well. We really don't have a good way to identify the severity of IFALD, so we want to act on it early. The only way that we can potentially determine this is a study that I did with the late John Fryer, where we looked at CRP, C-reactive protein, as a measure of inflammation. And when the CRP is substantially increased, then there's a substantial increased risk of death within 6 months. But that doesn't really help us because we don't want to wait till somebody's going to die in 6 months. So we don't really have a good marker. There are some risk factors for developing severe scar tissue in the liver, but again, these have not been perfected. A number of reasons why sort of staging the severity is difficult. We need to find a better, essentially a better mousetrap here. So that's it. So I'm going to stop, and I don't know if we have time to answer any questions. If we don't, certainly happy to take emails from people or what have you.
Well, thank you, Dr. Buchman, for that. I really appreciate that. I think one of the biggest questions, and we don't have time now for 4 questions, but we can get those to people, but it's the reactive versus proactive. I think so much of healthcare is about reactive, and I would love to see more, like you're talking about, of guidelines and so forth, of how we can talk to our clinicians about being proactive about some of these things. So thank you so much for your time today.